Today we're going to look at the stroke scenes from the TV show The Pitt, and we're going to judge how medically accurate they are. The Pitt is supposed to be one of the most accurate medical dramas out there. So let's see if this applies to the neurology aspect too. My name is Dr. Sater. I am a neurologist and pain doctor in New York and Connecticut. All right, code stroke. Let's see. This is a flashback to residency days.
Hi, what's your name? Nod your head if you understand. Open your mouth.
All right, so this patient is basically coming in as a code stroke. And a lot of the things they're saying and the process is actually very accurate. Basically, when a patient comes in as a code stroke, we do a very quick neurological evaluation to see if it fits any of the stroke syndromes or if it's potentially a mimic, because sometimes it could be that it's a seizure or that it's, something completely different. So in this case, they are examining her and they're basically saying out loud what the deficits are. But, the patient is not really verbalizing. You can't really see her kind of saying anything meaningful. So that's what we call aphasia, which is controlled by a specific part of the brain. We'll come back to that in a second. But essentially, they're saying that her left motor is intact, but she seems to be having weakness on the right side. So that's a very common syndrome, which we call left MCA syndrome, where basically the left middle cerebral artery, which is this guy right here, this is the vessel that feeds the left hemisphere of the brain. And for most people who are right-handed, the left hemisphere of the brain controls right side of the body and language. And so if the blood flow to that part of the brain is interrupted, such as in a stroke, then basically that part of the brain dies down and doesn't function properly, right? So then whatever functions it was responsible for, which in this case are language and movement of the right side of the body, are going to be affected. Now, time in this case is paramount, right? So we have a saying in neurology that time is brain. And that's because the longer you wait, the more neurons will die. And then the loss of function will become irreversible. And we have a golden window that's usually about 4.5 hours to administer the clot-busting medications like TPA and TNK need to be administered in the first 4.5 hours from what we call the last known well, which is not always known. But anyway, let's take a look and see what happens now.
IQ check is 73.
Straight to radiology. CT brain without contrast, perfusion scan, CT angio head and neck.
Okay, so he's basically saying, straight to radiology to get a CAT scan and a CT angio, and that is all very correct. So as soon as the patient arrives to the emergency room and we're suspecting a stroke, then we take them right away to get a stat CT head and vessel imaging, what we call CT angiogram. And the idea behind that is that there's two different types of stroke. You have what we call ischemic stroke, and then you have hemorrhagic stroke. So if the blood flow to a part of the brain is interrupted, that leads to ischemia. So the brain cells in that region will die down, and that's ischemic stroke, right? However, there are other types of strokes where basically the problem is due to a bleeding. So if you have a hemorrhagic stroke, then essentially you have blood in that part of the brain, and ultimately it leads to a loss of function too, but it's very different because now it's not so much that the circulation is interrupted, but it's more that you have blood. And the management of these two different types of strokes is completely different, as we will see later. But essentially, the first step is to get a CAT scan, which is very good for detecting blood. And we do the vessel imaging too to see if there's any occlusion in the vessels inside the brain. So if there is an occlusion of one of these guys, a lot of times we'll be able to see it on the CT angiogram. And that also opens up the possibility of interventions we can do. Okay, let's keep going.
Can you get a name on her?
We looked, couldn't find a wallet or an ID, but we had to jam out of there. Who called 911? Her teammate in Houston who called 911 here.
Yeah, okay, excellent questions and excellent points. And a very common realistic scenario over here, which is basically that the patient's last known well is not known, right? It seems like there was some kind of online gaming forum where, people noticed her absence, but we don't really know exactly when the stroke happened. And unfortunately, this is more common than we would like. And so we need to do a lot of detective work sometimes to figure out who the patient is, especially if there's a loss of language. And sometimes it's a matter of trying to decipher when that last known well was, because it has a huge impact on what we can offer the patient and what would be safe or not. If the patient presents within 4.5 hours of that last known well, then a lot of times we're able to offer that thrombolytic medication, TPA or TNK. However, if they are beyond that 4.5 hour mark, then the only option we'd be able to offer would be thrombectomy, which is essentially taking out the clot by going through the vessels. and that is an interventional technique. We call it mechanical thrombectomy, and it's only done if, with certain indications. So it has to be within 24 hours of the onset of symptoms, and there are other criteria that are essentially contraindications to it. But the first step is to get the brain imaging and to get a better history and make sure that this is indeed a stroke. And a very important point that they raise over here is that the patient is very young. So they're saying that she's in her 20s. She looks a bit older, but let's say, she is indeed in her 20s. Then that's an uncommon age. It does happen. I've seen a lot of strokes that happen to patients in their 20s or younger sometimes, but that's not the classic age for stroke. Usually, more commonly, stroke will happen in patients who are 50 or above with the common risk factors like high blood pressure, cholesterol, diabetes, smoking. So these are the most common risk factors. However, stroke can still happen in younger patients, including patients in their 20s, if they have the risk factors for them. So that can include things like drug use, that can include things like infections, that can include bleeding disorders and coagulopathies. Some people are more prone to clotting, for example. That can include, a problem with the heart, like a PFO, a patent foramen ovale, which basically means that a DVT, a clot in the leg, can actually travel all the way up and go to the brain. Again, none of these are common, but they can happen. You have also causes like dissection, so artery dissections in the neck that can actually lead to a stroke in younger patients.
I believe, but there's a carotid artery dissection left neck with a thrombus that threw a clot to the left middle cerebral artery.
So it looks like the imaging is back. There's no bleeding. So we're talking about an ischemic stroke and not a hemorrhagic stroke, which is good. And then now they're saying that she has a carotid dissection and a clot in her MCA, which is kind of what we suspected based on the presentation of the patient. And that's a classic syndrome. It's not uncommon. Now, how does this happen? So the vessel itself is actually not shown over here, but the carotid is really the one that comes from the heart, and then it will bifurcate and lead to different vessels inside the brain, including that MCA, which is the bigger one. Now, what is a carotid dissection? So a carotid dissection is basically when the vessel wall gets torn. So that tear can happen for different reasons. But in a young patient like this one, the most common things would be if she has a connective tissue disorder, like Ehlers-Danlos syndrome, for example, which makes lining of that vessel wall more fragile and kind of more prone to dissection. But then other reasons could be, let's say, if she had a chiropractic manipulation. So neck manipulation with chiropractors, especially high velocity, low amplitude manipulations, these are a risk factor for carotid dissection. Now, we don't know the full story here. We don't know if she was at a chiropractor the day before or something like that, but that's something to keep in mind, especially in a young patient like her. And so when that tear happens in the vessel wall, there could be potentially formation of a small clot that can then travel and then go to the smaller vessels of the brain and lead to the stroke. So now we know the reason, and let's see what we're going to do about it.
TNK is still the best clot busting possibility.
Shouldn't we do endovascular therapy? I mean,
Okay, I actually, looking at the patient now in bed, I like a few details that maybe are lost on the general audience. But, one, you can see that she has a right-sided facial droop and that she doesn't really have any asymmetry in her forehead. And that's classic for this kind of stroke. A lot of times in medicine and in neurology, we have to differentiate between a facial droop that's caused by a Bell's palsy, in which usually the whole face will be affected, including the muscle that you see right here, the frontalis, as opposed to a stroke like this one, an MCA stroke, where basically that muscle will be spared and then only the lower face will be affected. And you can see in this case that her right nasolabial fold flattening, but her eye and above her eye, that part of the nerve is functioning, which is very realistic. So kudos to them for getting the neurology right. The other thing I will mention is that you see the head of the bed is up. Now, it could be, accidental, but this is something that we actually do when we have a patient coming in with a stroke, and it has been shown to help with outcomes.
What do you call a Tyrannosaurus under stress?
what?
Nervous Rex.
All right, so the neurologist is here, and he's cracking some nerdy jokes, which is, believe it or not, very typical. We have a lot of neurologists are like that. So I would say that he's definitely, a typical neurologist in that sense. So there's probably going to be more corny jokes to come. But anyway,
How's the patient?
NIH stroke scale of 27, no last known wall time.
NIH scale is basically what we use as part of the neurologic exam to see how bad the stroke is. So the higher the number, the worse the stroke. And you get specific marks for every function. For example, every limb, if you can move it, that would be 4 marks. If you cannot move an arm, that would be 4 points. If you cannot speak, that would be 3 points, and if you cannot see, that's, additional points. So we add them all together and we form an NIH score. And that's essentially what will determine the kind of interventions that will be a possibility for the patient, because the risk and benefit ratio will depend on those scores.
Dr. Meadows, should we take her to EVT?
Not yet. Take first spin in the MRI, check for irreversible damage first. There's a diffusion flare mismatch.
So in this case, because the last known well of the patient is not known, then you can't really rely on that 4.5-hour window. And so that's why they're doing an MRI. And with the MRI, we have different sequences. One of the sequences looks at the water diffusion, and that can tell us very quickly if a stroke has happened acutely in the past, let's say, with 15 minutes of interruption of blood flow. And then we look at other sequences that usually take more than 24 hours to show anything. So if there's a mismatch between the two sequences, then we can time that the stroke has actually happened between that 0 to, 4 or 5 hour window, for example. And so that would make them eligible for getting the thrombolysis.
What type of person is best suited to work with an MRI?
A trained technician.
Someone with a magnetic personality.
I don't know how appropriate it is to be cracking jokes when you have a stroke patient. Some doctors actually do it. It used to annoy me a lot in residency, but people are quirky. So they're giving the patient the thrombolytic medication. We have 2 main thrombolytic medications we use. Essentially, they're clot busters. And one of them is called TPA. The other one is called TNK. The real full name is long and difficult to pronounce, so I'm going to spare you and spare myself. But essentially, these are the 2 main options. And they can have a bit of a different indications, but they're generally both pretty good.
How are you feeling?
Are you trying to say okay?
Yes.
Okay, so the patient is getting better in real time, which is indeed what we see in real life. When you get rid of that clot by thrombolysing it and the blood flow is restored, then you start to see the return of function. It doesn't happen instantly, it takes a few hours, but you start to regain that motor strength and also some of the language function. So you know at least that you're going in the right direction. In those, and usually we monitor the patient extremely closely after that TPA. We put them in ICU and we do Q1 hour checks on them. So every 1 hour we check the neurological function. We repeat that NIH scale.
A little bit of stridor.
Swollen lips, swollen tongue.
Vera, this is a side effect of the medication we gave you.
Oh, wow. Okay. So it looks like the patient is having very acute tongue swelling. We call that angioedema, which is a known complication of several medications, but including the TPA and TNK. It happens in about 1 to 8% of people getting those medications. So it's not super common, but it does happen. And when it does, we do have ways to treat it. The important thing is to make sure that the airway is protected. So sometimes we have to intubate. But first we try medications like steroids, epinephrine in certain cases, and other medications that can potentially bring down that swelling. So it looks like they're doing the right thing here.
It's anaphylaxis, get Robbie.
Angioedema is not always anaphylaxis.
I know, but it can progress to it and cause an obstruction.
I can reverse.
Okay, so she's contradicting herself because she's saying it's not anaphylaxis, and yet she's saying that she wants to reverse with epinephrine. Technically not, the two don't really fit together. If it is indeed anaphylaxis, then usually you get a rash with it, you get, the stridor, you get the swelling, and then you do give epinephrine. However, a lot of times when TPA or TNK is giving that kind of a reaction, it's actually not through an anaphylactic mechanism. It's more of a bradykinin-mediated mechanism, like what we see sometimes with ACE inhibitors and some blood pressure medications. And for those, it's a different kind of treatment that doesn't involve epinephrine. And especially when you have a stroke, epinephrine can, spike up your blood pressure, so not ideal in a stroke scenario, as it can lead to a higher risk of brain bleed. But let's see if the epinephrine is going to work.
Angioedema with stridor, respiratory's on their way. We should intubate, right?
Good BP and O2 sats. Epinephrine can reverse the swelling right away.
Okay, so the med student is confused, and it looks like there's a lot of confusion as to whether they're going to intubate or not, if it's going to be epinephrine or not. I think in this case, it's good that she's trying to help, but she should probably just chill and let her resident do the job instead of confusing everybody in the room as to what the plan is. So you don't really want to step on the toes of your resident or your attending or the fellow or whoever is above you in the room, because they usually know what to do better. So it's okay if you want to give your opinion, especially if they're missing something, but just don't change the whole plan in front of everybody. It's not good form.
Are we intubating? Are we not intubating?
Not.
Strider is improving.
Is it getting easier?
All right, so the patient is improving in real time and that swelling is going down in real time, which is accurate. We do see that. And so looks like the epinephrine worked in this case. So that's good, and there's no need to intubate.
Slow-mo, no-mo. Sorry, I think Dr. Menta
Eh.
is rubbing off on me.
Slow-mo, no-mo. So basically, for patients like her, especially when you have the MRI and everything, then you have the option of doing an IV thrombolysis first. So that was the TNK that they gave her. And then after that, you take them for thrombectomy if there is a big clot inside the brain, which there is in her case. And so that has been shown in multiple clinical trials to have better outcomes in terms of neurological function and recovery. So that's what they're doing now. And thrombectomy basically means that you go in through the groin and then you go all the way up to the blood vessels inside the brain, and then you retrieve that clot so that you can recanalize the actual vessel and restore blood flow. But again, there's very clear indications for it that are based on both the CAT scan, the imaging, and also based on the timeline and based on the overall deficits and whether or not there was improvement with the thrombolytic or not. So it's a pretty complex procedure. And also not all centers offer it. So it has to usually be a very dedicated stroke center. Otherwise, it's not going to be an option for most patients. And sometimes we have to transfer the patient out to a stroke center if they are eligible. Okay, so that's basically it. Nice show. I think they're pretty spot on when it comes to the stroke code and its management. I would say that this is pretty much how it happens in real life. If you want me to make more videos like this and react on other episodes of that show or other shows, let me know in the comments below. Thanks again for watching, and remember, time is brain.